So, this is going to be a little bit of mix of overview of pancreatic transplant, of course, with special emphasis on pathophysiology because that might help us to do monitor the patients well. So, if we talk about the prevalence of type 1 DM, though it seems to be rare, but the, the people now who are surviving type 1 diabetes, contrary to almost half a decade back, are now increasing. And with, of course, with improvement in treatments and availability of insulin and so on. So if we see the worldwide map, there is a very steep gradient from north of the world to the south. Like the highest prevalence is being seen in North America or North Europe. India, the prevalence is somewhere between 2 to 5 per 1 lakh children years. However, considering our population, we have almost lakh or so of type 1 diabetes. So the burden is quite huge. And if we talk about the age of onset, initially it used to be classified as a juvenile diabetes. Now that classification has gone. The type 1 diabetes can be diagnosed during part of life. Of course, the peak prevalence, as we are seeing here, is around the age of puberty, because that is being said that at the time of puberty we have increase in sex hormones and growth hormones, which somehow facilitate the immune destruction of beta cells. So the maximum prevalence is being seen around at the age of 14 to 15 years. Now, when we talk about the etiology of type 1 diabetes, it results from a complex interaction between genetic factors as well as the environmental factors. If we talk about genetic predisposition, several HLA classes has been identified which specifically predisposes to development of type 1 DM. And then there are certain non-HLA genes also, we'll discuss them. And of course, there is an increased risk of development of type 1 DM. In contrary, what we believe in type 2, type 1 also have a familial predisposition also. And then there are certain environmental factors that contribute to the development of diabetes, like certain viral infections, especially the classical one that is being associated is Coxsackie B virus or enterovirus. Then there have been some correlation if there is early introduction of cow milk, yeah, before the age of 4 months, or very late introduction also at the same time. Then so all these things can contribute to the development of type 1 DM. Basically, again, and this is also, it relates to the development of gut microbiota. Gut microbiota has been shown to immunomodulate to modulate the immune system and makes us more tolerant about our own self antigen. So whenever we introduce the external feed, that is also going to decide when we are going to develop all these autoimmune disorders. Then altitudes, again the theory is vitamin D deficiency somehow again leads to decreased immune self tolerance and leads to more development of autoimmune disorders and so on. And then white ethnicity and other things. So this is just a heat map which is just showing how the pattern or the contribution from genetics to environmental factors have changed. Like this is the 1 century old where the and genetics used to play a big role compared to the environmental factors. And now the environmental impact of environmental factors are increasing more at just the beginning of 21st century. So the contribution from environmental factor is increasing day by day. So these are the various HLAs. So certain are high risk, certain are high risk HLA types, certain are some of them are protective. So there is clear cut association with HLA phenotypes. Then there are certain, now the GWAS has opened up the Pandora's box. So now we have almost more than 50 other genes other than HLA association, that is non HLA genes. Especially some there are two most important gene is insulin, and second one is protein tyrosine phosphate phosphokinase. So these two are the most important proteins against which in which if there is a mutation, there is a more chances of development of type 1 DM. So we are going from HLA to non HLA genes. And then if we talk about so because of these genetic predisposition, we have been able to study the families more, and because of that, now that we know there is a familial predisposition, there has been a study of development of, or the timing of development of antibodies, then ultimately development of dysglycemia, and then development of frank diabetes. So based on this, pre-diabetes, borderline diabetes used to be the phenomena which we used to know, familiar about the type 2 diabetes. Now in even type 1 also, now we have stage 1, stage 2, stage 3. Like stage 1, when the patient have only antibodies but no dysglycemia. Stage 2 is where there is an antibody positive and there is a dysglycemia, but it is not cutting, crossing the threshold of what we call as diabetes. And then stage 3 is like development of frank diabetes. Why it is important now staging and diabetic pre type 1 diabetes is because we have some immunomodulators like teplizumab, which can work in stage 2 or in early stage 3 as soon as when the patient is being diagnosed. There have been reports where we can achieve the remission of type 1 diabetes at least for few years. We have few years data till now, almost 4 to 5 years. So that is why identifying these antibodies in family members, healthy family, so called healthy family members, can gives an opportunity to prevent the development of type 1 DM. So this is how these stages are being divided. As I just said, that it is stage 1, stage 2 is antibody positive, and stage 3 is antibody positive plus dysglycemia. So what happens exactly in type 1 DM? So there is, it is basically the uh, the job of killing the beta cell is being done by cytotoxic CD8 T cells. So and that is being facilitated by the B cells as well as the CD4 T cells. That is, and ultimately formation of these antibodies leads to more efficient presentation of various pancreas beta cell related antigens efficiently to cytotoxic T cells, and ultimately cytotoxic T cells are the main executioners of the beta cell toxicity by way of perforin and other enzymes and so on. So it's basically, so type 1 is not a metabolic, it's more of an autoimmune disorder where the destruction of beta cell results from by various immune mediated cells. So there are multiple so the classical findings which have been seen in patients of type 1 DM who some on autopsy is insulinitis, and the specific and this classical infiltration of various immune cells are limited to only to the islets of Langerhans cell. So and other the part of the pancreas are relatively spared, and as I just said that it's the CD8 T cells which kills the cell directly, and of course there is a predominance of Th1 immune response compared to Th2 and leads to more of a autoimmunity generation. And uh, uh, so this is just to highlight that this is the we can see intense mononuclear inflammatory cells infiltration into islets, and ultimately when the beta cells are being destroyed, very few inflammation actually left behind. So it is the and somehow this is the decreased levels of the regulatory T cells which contributes to the development of this autoimmune disorder. Now I think one of the key aspect of management is in monitoring the antibodies. So that is how we make the diagnosis also, and that can be used during the monitoring of the patients after pancreas transplant to decide whether there's whenever there's a insulin independence is getting lost, then what is the exactly cause. So these are the four types of antibody which we screen mostly in our patients for diagnostic part, because nowadays again the gray the differentiation between type 1 and type 2 is also becoming difficult sometimes, because now type 2 is, now we are seeing patients in second decades of 15 year 14 year, which we never used to see. It was always 20, 30 years, 40 years old. So sometimes we are in dilemma even within the 11-year-old child coming to our OPD is actually type 1 or type 2, because once we label him as a type 1, he will be on insulin. Believe me, no one is going to change that label, and no one is going to have that daring to change it. So now especially in second decade or third decade, where we are seeing both early type 2 as well as type 1, we do these antibodies just to make sure that we make a right diagnosis, and depending on that we make give the right treatment. At the same time, that type 2 DM also happens in India with not so called overweight and obese BMI. We are having the type 2 in India with lean phenotype. So sometimes it becomes very difficult to differentiate these two. So we do these four antibodies, and the most common one is the GAD65 antibodies, which appears little later but persist longer in type 1 diabetic patients, and then comes the insulin autoantigen antibody, or tyrosine phosphatase antibody, which appears early and actually presents with type 1 DM in childhood is below 10 years. And then later on, development of IA2, IA2 and zinc transporter antibodies leads to acceleration of autoimmune destruction and leads to fulminant development of diabetes. So now, as I said, that there is a pre-symptomatic stage. So presence of one antibody in family member carries a risk, but the risk is small. But as soon as we have more than two or more than two antibodies, the risk of development of diabetes becomes very significant. Like within next 10 years, almost 70% will land up with development of type 1 DM. So that is why how we can predict the development of type 1 DM, and sometimes can actually intervene also. Now even if somebody is having two antibodies, whether they are, how soon they are going to develop, at what rate they are going to develop, depends on the titer of antibodies, their that affinity towards antigen, at what age they have a shown the seroconversion, and so on. So all these things are going to decide how soon the patients are going to develop diabetes. So this is just so why type how do we treat it. So of course the initial treatment is insulin replacement, but now and then because of the technological advances, especially in India, whenever patients are affording, of course we cannot give it to everyone, we are going for pumps and all. Especially now we have almost semi closed loop pumps, and or the almost hybrid closed loop pumps. So we are managing with them, but still there is a lot of unmet need which we need to again fulfill. So that's how the where the role of pancreas transplants comes in, which may be role of beta cell replacements come in. So we are shifting modes from insulin replacements to beta cell replacements, and then which may be in various forms, which may be in pancreas transplant, which may be in islet transplant, now the stem cell transplants, and so on. So now so the as of now, the basic need where we need the transplant or beta cell replacement is the patients where there is a significant degree of hypoglycemia, and with hypoglycemic unawareness, where in spite of best possible insulin replacement regimes, patients develops significant episodes of hypoglycemia, especially without awareness, and then they can land up in coma and permanent cell damage. So these are various strategies of replacing beta cells. I'm not going to go in detail because I think they are going to get covered in subsequent sections also. So this is the overview how the transplant has evolved over a period of time for the treatment of type 1 DM. And then there we have different selection options available depending on the patient profile, whether they have only hypoglycemic awareness, whether they have simultaneous ESRD, and depending on that we can go for these two. So yeah, I think my time is getting over. So coming to the main thing, so the problem is basically, so we'll go to this. So anyway, so whenever we start talking about beta cell replacement, the problem is it's an autoimmune disorder. As soon as we replace it, there is always a fear of autoimmune response getting re-triggered and ultimately redevelopment of type 1 DM or the graft failure. So and the incidence as this has been reported anywhere from 2.5 to 8 to in fact 15% depending on various studies or so on. And so how can we identify that again? So again the pathophysiology comes, the here comes the role of initial pathophysiology. So we can identify the the reason of insulin requirement getting back again by either maybe there may be technical problems, there may be the issues with the organ per se, or there may be specifically autoimmune targeting of the beta cells of the
Sir, request you to please sum it up.
yeah. So we can just check the titers of the antibodies whether it was there or not initially at the time of transplant, or there is increase in titer that can tell us about whether it is the beta cell destruction which is causing the graft function loss. And this is and then we can of course do the biopsy, which will classically show only insulinitis rather than the diffuse infiltration of the organ by the various immune cells. So I think then I'm going to skip with this. So recently we are going towards more in direction of stem cell transplant, which can be modulated later on to immune tolerant cells also. And this was a recent study which was just published in June 2025, first trial, forward trial, which have shown almost 83% of graft function at the end of 1 year. I think with this I will end, and thank you.